It's good to see everyone. Today's topic is end-of-life care and nursing issues. Just a reminder to mute yourself, and after the presentation, we will have time for discussion. You can put your questions in the chat, or you can at that time either unmute yourself and ask a question. And then after the talk, we will have a case presentation by Erin. So I'm going to go ahead and introduce Dr. Hunter, who will get us started with the presentation. Welcome.
Thanks. Good morning, everyone. Can you hear me? Great. All right. I'm going to go ahead and try to share my screen. Get things going. Does it look like you see slides?
Yeah. Yeah, looks great.
Great. Great. Thanks. All right. I'm Dr. Hunter Groninger, and I was moderating the session last week, or facilitating the session last week. I'm a palliative care physician in Washington, D.C. in the United States. And today I'm going to talk about care of patients and families in the last hours and days of life. All right. So what I'm hoping to do in the next few minutes is talk a little bit about physical findings that you may discover during your assessment of patients that sometimes we refer to as the syndrome of imminent death. We'll talk more about that. I'd like you to be able to name common symptoms that are associated with the dying process, because that will influence your approach to care of these patients and preparation for assessment and management of these common symptoms. And then finally, I'm hoping that after this session, you will be able to describe the role of a multidisciplinary palliative care team in family support at the end of life. Because remember, after all, in palliative care, we focus not only on the patient, but also on the caregivers and the family that is involved in the patient's life. So let me start with an example case that we can reflect on, and I invite people to think about the case now and throughout the rest of our time this morning. And if you have questions or comments, please feel free to unmute and ask them, or feel free to put them into the chat. And I know there are people who are watching the chat and can signal when there's a comment or a question that we should respond to. So in this example case, let's consider a 56-year-old woman with metastatic breast cancer who is no longer receiving any anti-cancer therapies. She has a family that includes her husband, her brother, and 3 children. And her family describe declining physical function and activities in recent weeks. And they paint a picture of her as someone who is bedbound, spending all the time in bed, with minimal food intake or water intake. And they notice that occasionally she seems to be hallucinating, seeing things that aren't there, hearing things that are not there, and often is moaning. So to start off, what are some sources of suffering here that we might want to pay attention to? Maybe I'll just give everybody a few seconds to think about that. And if you have any thoughts about what, as a palliative care provider, what are some sources of suffering that you want to be paying attention to right now? So either share some thoughts, or you can put them in the chat. And those who are monitoring the chat, please let me know if you notice anything.
Somebody was saying hallucinations.
Mm-hmm.
Or a question you could ask or explore. I think that was, what are some sources of suffering?
Yeah.
I think
hallucinations, for sure. That's something that could be concerning to the patient and also to the family. What else might be going on to pay attention to? Being bedbound, not able to perform activities of daily living, absolutely. So remember, this is a family unit, and um, perhaps our patient is someone who's actively engaged in caring for the children, or perhaps she was working before, um, and that's a big change to the family.
There's
What's
also a
going on?
question about exploring what the moaning might be. Is that pain? Is it agitation?
Mhm. Yep, that's right. So what's going on there? Is that part of the hallucination? Is that some physical distress? I see being bedbound can cause bed sores. Absolutely. And then kind of some bigger questions related to fear of loss. So this is a big change in the family unit as the matriarch appears to be dying. Spiritual pain, fear of death. So these are great. Maybe I'll stop there. Those are great comments. That's a great some great ways to begin to engage with this case. So some of the things that I'm hoping that we'll talk about in the next few minutes are sort of what is happening here clinically and physiologically, but then also, as some of the comments and questions are underlining, what's happening in the larger scope of things. What can we tell the patient and the family about what's happening? What symptoms should we be looking for? And how can the entire palliative care team assist? So let's approach some of these questions. So first, I'm going to talk a little bit about what the clinical literature often refers to as the syndrome of imminent death. Sometimes we might more casually refer to this experience or this event as last hours of life. And when people talk about the syndrome of imminent death or the last hours of life, sometimes we talk about different stages. An early stage where a patient might be bedbound or spending more time in bed with a lot less intake by mouth, sometimes with cognitive changes like sleeping more, and they may also exhibit a delirium. That could be a hyperactive delirium, very agitated, or a hypoactive delirium, very sort of sleepy and not engaging, or a combination of the two. Maybe a middle stage might be just more of the same, especially with a further decline in mental status. And then very late stages, we often may notice excessive pooled oral secretions, which are sometimes casually referred to as a death rattle. A patient may slip into a coma, experience fever, or altered respiratory patterns. And we may see changes in the skin, particularly in the limbs, with skin changes becoming more dusky or darkened with changes in circulation. So this is, I guess, in summary, many patients experience this common pathway physiologically as the body is shutting down through any advanced illness. And sometimes it's important to be trying to think about what is the time course that we might predict or expect when a patient is exhibiting this syndrome of imminent death. And there's a range from some number of hours, maybe less than 24 hours, up to several weeks. And everybody's a little bit different, but part of our role supporting the family, and a really common question that we might be asked by family members, is how much more time does our loved one have? So maybe in a very short time frame before death, less than 24 hours, we might see a patient who's very cachectic, someone who has had a progressive illness for some time, and progressive functional decline. And this syndrome of imminent death really may kind of be a hallmark of really advanced illness over a long period of time and herald death within some number of hours or a couple of days. Someone who is well nourished, or perhaps was previously healthy but had an acute event, either an acute illness like coronavirus, or a traumatic event that is leading to death, that syndrome of imminent death may take a longer period of time because there's more physiologic reserve in the body. So kind of thinking about this time course and what I've suggested to you in terms of a spectrum, where do you think our patient might be on this spectrum from what we've shared in the case? Any thoughts about that? So maybe, when I described our patient, I talked about how she had an advanced illness. She had a long course of cancer. She was no longer receiving cancer therapy and was much more cachectic and had some functional decline. So for her, her time course might be more on the order of some number of hours to a couple of days. And here's some common family concerns that arise at the time of the last hours of life. These are some common questions. And maybe we'll go through the questions here, and then I'll give some examples of how we might begin to approach answering these common questions. Is our loved one in pain? And how would we know? One of you had pointed out, I think accurately, we should wonder if the moaning behaviors is a sign of physical discomfort. Is our loved one starving to death? She's no longer eating and drinking. What is the implication of that? What should we expect? How should we know that time is very short? Should we stay by the bedside? Can she hear what we're saying? And what do we do after death? So these are all really common questions that arise in this setting, again, with any advanced illness. So I think it's really important that we develop some comfort addressing these. So let's talk a little bit about management strategies. How do we begin to address these questions that I just shared with you? I'm going to share some example responses just for your reflection here. And I think it's really important, both as part of this course and part of your work experience in palliative care, to really think about how you will respond to these questions, or how you do respond to these questions when they arise in different settings, and develop your own sense of how you feel comfortable answering them. Because again, they're very common questions and common scenarios. I'll choose a couple and we'll talk a little bit about this. Is our loved one starving to death? That's a common worry, because in every culture that I'm aware of, food and eating and drinking is part of being alive and part of staying healthy or getting healthy, recovering from an illness. And in the last hours of life, the body is really no longer able to do that. And it's important as palliative care clinicians to know that and be comfortable reassuring families, no, your loved one is not starving to death. Stopping eating, stopping drinking is a normal process of the body shutting down. And there's no evidence that your loved one is experiencing a starvation, a desire to eat and drink and just not being able to. It's really important to reassure family members about that. Can our loved one hear what we're saying? That's a very common question. And I often answer, it's impossible to know for sure, but I really recommend talking to your loved one as much as you would like. Sometimes it feels as if hearing is one of the last sensations to disappear. And certainly your loved one knows you and knows your presence more than anyone. So if there's something important you want to say, or you want to just reassure them that you are nearby, talk to them and feel free to do that. And finally, what do we do after death? I think it's really important. Certainly I can certainly say in American culture, it's important to teach families and remind families that death in itself is not an emergency. It's something that we're planning for, we're talking about and preparing for. And so it's helpful to reassure families that as a palliative care team, we'll make a plan with the family for what to do after the patient dies. So they know what to do, since death can come, sort of unpredictably at any moment in those last hours and days. And then I want to talk a little bit about how to involve the palliative care team. Remember that this is interdisciplinary work that we do. And just as the case started to illustrate, there are physical components of suffering that we need to be looking out for, as well as psychological, social, and spiritual modalities of suffering. And some of you pointed out potential spiritual distress on the part of the patient or the family as our patient is dying. Some of you pointed out some social distress with the breakdown of the family unit. As the matriarch of the family is dying, and that will forever shift the structure of the family. And psychological distress. This is a loved one that's that they're about to lose. And so it's important that we're aware of that and looking out for that distress and able to provide as much support as possible to family. And for those of you that are used to working with children in particular, being aware of how children understand death and how they grieve is a very important part of the care that we deliver. So let's talk a little bit about practical actions for managing the last hours of life or the syndrome of imminent death. First, I think it's really important to confirm treatment goals at this time in the patient's life and make any adjustments that are needed. For example, it's really important to look for medications that should be stopped because they are not promoting the goal of comfort. And there are a lot of medications that sometimes are prescribed that people take for a long time. Medication for blood pressure, medication for cholesterol, for other diabetes, for other chronic diseases that in this final stage of life are not relevant and not constructive to promoting comfort in the last hours of life. And I use this phrase that I've shared here. I use this phrase often, everything that will promote our goal of comfort and stop interventions that are not helping that goal. And that, I think, that often helps families to understand that even though you're recommending stopping some medication, that you're actually doing something that you believe will be helpful to promoting the goal of comfort. It's important to communicate very clearly what's happening. You might say, this patient is actively dying, or I do not think that your loved one will live for very much longer, so that people really understand and are able to prepare for what is happening. Mouth and skin care is extremely important. It's something that I know physicians sometimes overlook, and I look to our nurse colleagues in particular to be reminded of the importance of this. That's a really important part of what we do at end of life. And we've talked about counseling and support to families in different ways that can take place. And finally, being aware of potential symptoms and signs of distress as they arise so that we can address them immediately. I always think of this list of symptoms, really common symptoms during the last hours of life, and I look out for them and I prepare a plan in case they arise. And I think it's really important as palliative clinicians to be aware of this list. I think this is pretty comprehensive for the syndrome of imminent death. And as you provide care for patients at this stage in life, to be on the lookout for each of these symptoms and have a plan ready in case something arises unexpectedly. So look for them every time you visit and have a plan. And then a lot of what we do in palliative care is educating patients and educating families. So excessive oral secretions, something that as a patient loses the inability to manage oral secretions, to swallow easily, that death rattle is something that can be quite alarming to families. There are medications that we can try to dry up those secretions. Sometimes that works, sometimes it doesn't. Sometimes repositioning is even more effective, but reassuring family members that this is unlikely to be associated with any discomfort on the part of the patient is really important, so that families are not distressed by it. So in summary, this is what I hope we've covered today for the last hours of life: recognizing the syndrome of imminent death, the importance of interdisciplinary communication and support to the family, and being sure to involve the family in our palliative plan of care, recognizing, planning and communicating and managing common symptoms in the last hours of life. I hope that our case has covered a lot of that today. It has given you some tools to take into your own practice. With that, thank you very much. I will stop sharing and see if we have any questions or anything that we should be noticing.
I have a question. Sorry.
Please go ahead.
Hi, good morning, everyone. Thanks for the topic. It's really good and interesting. And what can I do if I have a patient who's really, who's dying, who's in the last time, and her family insists that they need that he or she needs to eat, needs to have some medicine. I have a couple of those. It's really hard. I told them that they don't need, the patient doesn't need, but they don't understand. They feel guilty if they don't do anything.
Yeah, that's a great question. And hopefully I tried to share some communication strategies to talk to families who have those concerns. It's a very common concern among families. I think that one initial approach that I have is first to reassure, as I shared in the talk just now, that an individual stopping eating and drinking is a normal part of the dying process. And that by itself is not uncomfortable. There is no evidence that that is an uncomfortable thing, that they are not suffering because they're not eating and drinking. I also share with patients and families that forcing nutrition or forcing hydration can often worsen how people feel. Forcing food by mouth can be certainly uncomfortable, if not dangerous, by aspiration. And I know that, when families want to explore enteral feeding or IV hydration or nutrition, I really explain that physiologically, it's not going to help the patient feel better. It probably will cause the patient to feel worse because the body is no longer physiologically able to handle the nutrition or the hydration the way that a more healthy person could. But I think that's sort of the kind of the medical clinical approach to that. I also think it's just really important to explore with families what they're worried about. You mentioned in your example, you mentioned families feeling guilty. And so it's really important as part of our comprehensive support to explore that and really understand what that's about. And on an individual level, explore if there are ways to reassure and relieve people of that sense of guilt. I see, actually, I'll just kind of comment really quickly. I see a comment around, is passing a nasogastric tube important at this stage? I'm glad someone brought that up. Thanks for bringing that up. Just so I can really openly say, it's probably most important not to do that, not to introduce a nasogastric tube or some other way of introducing nutrition for the reasons that I just mentioned. At end of life, I really think of a nasogastric tube almost never being particularly helpful. The only time that it really comes to mind in this moment is someone who has like some kind of complex anatomy, like a bowel obstruction. And for that reason, it's not actually to provide nutrition, but really just to extract gastrointestinal contents and relieve that pain and pressure and nausea, but not for nutrition purposes.
Thank you very much.
Sure. Great. Well, I'll look to Anne and Erin to decide when we move on, but we can continue the conversation as well.
Thank you, Dr. Hunter, for your presentation. Are there any, kind of final questions before we move to Erin for the case presentation?
Actually, and we do have the nursing content we wanted to cover today. So we, and actually the case presentation is an end of life case. So we might be able to get on to more questions about end of life when we get to the second part. Would that work?
Okay, perfect.
Okay. So we're now going to shift focus a little bit, and we're going to discuss some specific details related to palliative care and the role of nurses and nursing nurses that are specialized in this field. Of course, we want to make sure that all of our physician colleagues and our social workers and counselors, whoever's on the call today, pharmacists are not going to just kind of shut their ears for this part of the conversation, but it is a very important part of palliative care. So let me just share my screen. And then we'll get on to the nursing issue. Okay, so my name is Erin Das. I am a palliative care nurse, and I've been helping organize this course for the last few months. Today we'll be talking about really specific nursing issues. And again, when we think of nursing, it's not just nurses that provide this support to patients, but it can be caregivers, it can be physicians or assistants, but of course, mainly it is the nurse and the role of the nurse that we're going to talk about here. With nursing and nursing in a humanitarian setting, we obviously want to pay much respect to the work that nurses do in these settings. Nurses work very long hours. They often don't get compensated for the amount of work and the care that they do day in and day out, just as I'm sure many other medical professionals do. But today we want to focus on the very specific things that nurses are very good at, and also give you, continue to empower you and teach you more skills specific to palliative care. So we'll cover 7 different topics today quickly. It's not a very in-depth presentation, but it will cover basics of what is important for our patients and our families. So first we'll talk about a bed bath. Then we'll discuss basic issues around transferring patients. We'll talk about skin care, then wound care or pressure sores or things that you may find in your settings. Also some teaching on mouth care, stoma care, and lymphedema care. So in terms of the bed bath, sometimes you will have patients that are bedridden, so they can't get out of bed, but it's still very important that we make sure that their hygiene is taken care of. So it's really important that patients that are bedridden and are unable to get out of bed and take a bath themselves have a wash every day or at least every other day. Very important that their face, their hands, and the perianal area is washed if they don't want to have a bed bath or they're feeling too unwell to do that. And oftentimes this can be done by one person, or it may be needed that 2 people are required. Some simple supplies are suggested: a small towel or a cloth, water, soap, a clean cloth or clothing for after the patient has had the bath, and then a plastic sheet for underneath the patient. So when we think about the bed bath, you want to make sure that you wash the patient well, that you provide comfort and, of course, dignity and respect to the patient. So as much as you can, make sure that there is proper barriers to provide privacy while you're doing this. When we think about transferring patients, oftentimes our patients are in bed and they may need to sit upright or they may need to go for a test in the facility. So we do want to talk a little bit about transferring safely. And the way we will do this is by first explaining to the patient what you're going to do. It's really important that you communicate to a patient and the family that you're hoping that they can get into a wheelchair or into a chair at the bedside, and not to do something quickly without their permission, because you do also need them to help with the transferring. So first you want to bend your knees as the caregiver. You fold the patient's arms in front of them, and then you put one leg of yours in between the patient's legs. So you sit at the side of the bed and you have the patient sitting as well at the side of the bed, and one of your leg is in between the patient's legs. Then you grab a hold of their trousers or whatever type of clothing they have at their waist, and you use that for lifting. You position the patient near the end of the bed, and you want to secure whatever chair or wheelchair they're going to be going into. You then lift the patient by bending your knees, and you shift them into the chair slowly, and you carefully put the patient into the chair in a comfortable position. So you want to make sure that you have that leg in between the patient's leg. In case they fall, they will kind of slide or fall onto your knee, not right onto the ground. As we now move into general skincare, it's really important, just as Dr. Hunter was explaining, that when we have our bedridden patients, or when patients are closer to the end of their life and they're not able to move as much on their own, we within nursing and medicine, we strongly recommend patients that cannot position or reposition themselves, that caregivers and nurses and medical staff reposition patients every 2 hours. And we do this, the reason we do this is actually to prevent pressure sores. So there's certain areas on our body that are more at risk for getting a pressure sore, and that includes the feet, ankles, or any bony area that a patient has, maybe their hips or their shoulders. It's really important that as we move patients in the bed, we do this in a proper way. And I'll explain that a little bit with a draw sheet, and that we do maintain their hygiene using mild soap and giving them a wash regularly. As patients and families are able, using moisturizing cream is really helpful. It doesn't have to be expensive. It can be very basic, but this is helpful for general skincare. And you do want to change linens of the bed, especially if a patient is in bed, is bedridden. You want to change the linens regularly. You may not be able to change them daily depending on the resources that you have, but definitely changing them regularly so that what they're lying down on is clean. Especially if it has been wet or soiled, if the patient is incontinent, you want to make sure you're changing that regularly so the patient isn't sitting in something that's wet. I'm not sure if you can access it in most of your facilities, but I do know that there are people that are working in urban settings on the call as well today. But if possible, you can also give a pneumatic bed to a patient, and that's an air mattress that has a rotation of air, which also relieves the pressure for patients. So this is what it looks like. So it's an air, or like a bubble mattress that's connected to electricity. And every so often the air is released from one pocket and then it goes into the next pocket, and it relieves pressure on a patient's body as they're lying in bed. We often recommend, here you can see this patient is quite cachectic himself, yet you can see that he also looks a bit weak. But here his caregiver very proudly is standing beside him, because it seems that she has really tried to take good care of his skin. So you can often use soft pillows to help position a patient that is very thin or emaciated, and it can provide a lot of comfort. As you can see by his feet, we don't put the pillow right on the heel. We kind of put it above the heel to reduce any pressure on the heel of his foot. So when we use a draw sheet, sorry, this image is not so clear, but when we use a draw sheet, we usually recommend 2 people to help, and we have it placed in the middle of the patient. It's not more at her head, and it's not more at her feet. It's placed in the middle of the patient before she gets into bed. And this draw sheet can help move a patient up in the bed. Sometimes patients, even though they're not moving very regularly, they often get shifted in the bed, and their feet can be closer to the end and can cause a lot of pressure on their feet as well. So what you would do is you would have two people there. You would obviously explain to the patient what you're doing, and together you would shift or transfer the patient higher in the bed safely without shifting any of their skin and just dragging them up the bed. You can do that with a second bed sheet, or we call it a draw sheet. So these are the areas that patients are at risk for more pressure. So here you can see on the picture, we have the elbow, knees, the heel, the inner knee, the hip, the great trochanter, the shoulder, and the back of the head or ears. So I do want you to pay more attention to your patients that are not able to move as much or would be at risk for pressure ulcers. Please pay attention to these areas of the body. And when you're making your daily rounds or your assessment, or you're even providing that bed bath, please assess that for any redness or discomfort or discoloration or even skin breakdown. So now as we move to wound care, many of our patients in our facilities or in a home care setting or a home-based palliative care setting may require wound care. So when we think about wound care, especially in palliative care, we're often treating wounds that are not necessarily going to be able to fully heal. You may have heard the word a fungating wound or a non-healing wound. Those are the types of wounds we often see in palliative care. So what I want you to remember and think about when you think about wound care is the daily cleaning wounds daily with normal saline or cooled boiled water. We don't want to use antiseptics because they can be very harsh on the skin. And this is not necessary for the types of wounds that we are using. So we do recommend that you irrigate the wound with a syringe, not using the needle. Try not to wipe a wound with gauze, because when you wipe a wound with gauze, it actually causes damage to the new tissue that is starting to grow. And sometimes there's even some of the fibers from the gauze that get into the wound, and this can delay your wound healing. So when you're providing wound care, you want to take the old dressing off. You want to clean the wound with that normal saline using a syringe to irrigate it. And then you want to dry the wound. At this point, the wound is clean, so you can assess if the wound has changed or if there's any infection that has occurred. And at that point, you want to prepare to put a new dressing on the wound. And for that, we recommend having a dressing that has Vaseline on the gauze, so that when you change the dressing the next day or the following day, every 2 days, the Vaseline will allow the dressing to come off easily and not rip any new skin or damage any new tissue that was already growing. So if you can access Vaseline or petroleum jelly, that's highly recommended when we talk about wound care. In terms of the role of antiseptic, it is not recommended to use antiseptic when doing wound care. There's a lot of research out there that says we should not use chlorhexidine, iodine, betadine, or hydrogen peroxide. These types of antiseptics and solutions can damage new skin cells, which are healing the wound. They do kill bacteria, but they also kill those new skin cells that are growing. And it's our priority to help the new skin cells grow. At this point, we're not so worried about the bacteria to be using strong antiseptics every time we change the dressing. So please get into the habit of using normal saline if you have access to it. If not, you can use cool boiled water. I also can share on the group a recipe for homemade normal saline. It's very easy to do, and we did it often in our home care practice. So I can share that recipe for the group as well. Sometimes in palliative care, we find very complicated wounds, and we find situations that are not easy to deal with. Patients have a lot of issues with their self-image because of the type of fungating wounds we see in our practice. Other issues that we find patients dealing with are pain in the wound, a foul smell, bleeding, and even maggots can enter into some of our wounds for our patients. Just if you can kindly mute, and it's easier for everyone to hear. So as we try and manage pain for our patients, we do recommend if you have a patient that experiences severe pain during the dressing change that you pre-medicate a patient. So if you know that the wound is quite large and the patient experiences a lot of discomfort when you change a dressing, we usually recommend you, you speak obviously to the medical team if they don't already have a pain regimen, but you give morphine 30 minutes before the dressing change, an as needed dose. Especially for children, it can be very traumatic, or if they've had previous traumatic situations with wound care, you can also give midazolam to settle the child before you give, before you change the dressing, and the dosages are there. For a foul smell, for fungating wounds, we often recommend crushed tablets of metronidazole or injection metronidazole. What you would want to do is you would take the old dressing off, you would clean the dressing with the normal saline, and then you would dry the dressing. You would then shake the powdered or the crushed metronidazole over the wound, or you can put it directly on the gauze, and then you put that as a primary dressing. There is also research using tea bags. It can be plain black tea or green tea. You would put this as a secondary dressing outside of the primary dressing, and then you would secure that with another piece of gauze and tape. And this we have found, especially within palliative care, we've tried it in Nairobi, and I know it's being done in Asia as well. It also absorbs and reduces the smell that can be so aggravating and so difficult for patients. Oftentimes, these dressings require frequent changes. And many times you'll have patients come into the facility and they're doing kind of home remedies of what they're trying to do to manage it. It is really important when you see a patient that you get a regimen or a plan in place for these wounds and these patients very quickly. But these recommendations work very well. In terms of bleeding, if you have a patient with a wound who has mild to moderate bleeding, we do recommend applying crushed sulforaphate mixed with Vaseline onto the dressing. You can also apply injectable transexamic acid, which stops the bleeding immediately, or adrenaline if the transexamic acid is not working. We also do recommend that you apply pressure just as you would for any sort of bleeding, kind of as a first aid technique. So that can also help. As we think about maggots, of course, this is the reality in many of our settings. It is very, very important that we keep and we prevent this from happening by covering wounds. There may be times where patients don't want their wounds to be covered, or they're doing their own kind of techniques to keep their wound, trying to heal their wound, but it's very important in many situations that we cover wounds so that maggots don't occur. The best way to get rid of maggots is actually to apply fresh meat directly over top of the wound. And what tends to happen is the maggots are attracted to the meat, including fish, chicken, or beef, because of the blood, and they go towards that. And then one by one, you would pick the maggots out. It's not an easy process, but it does work. Turpentine also does tend to drag out the maggots too. But again, don't put the turpentine on the skin. These dressings would need to be changed really frequently as well.
There was just a question, Erin, in the chat of what is a maggot? If you could maybe just explain and why they're there.
Yeah, they're back at the first picture. So the first picture in the middle there is a maggot. A maggot is I believe someone can correct me if I'm wrong, but I believe it's the beginning of a fly. So it's like the egg that's being that's grown kind of in a moist setting. So the fly lays an egg, and then the egg starts growing, and then it just flourishes in settings where there's raw skin. So maggots wouldn't be able to survive on skin that's not open or broken, but they thrive in those settings. And you can't heal a wound with maggots in it. So, and it's not a very pleasant experience. I'm assuming patients often can feel it. I'm sure it's not a nice experience. Okay, so on to mouth care. In terms of mouth care or oral hygiene, this should really be done 2 or 3 times a day. If patients are not able to brush their teeth or they have sores in their mouth, they can also gargle with salt or sodium bicarbonate. So that would be 1 cup of salt to 1 teaspoon, 1 cup of water, not 1 cup of salt, 1 cup of water to 1 teaspoon of salt or sodium bicarbonate, which is baking soda. And that can be gargled and then spit out. We usually recommend that you get your patients to lubricate their lips, especially those that are on oxygen. They can get really dry lips and dry mouth. It is recommended mouth care is done after people eat, to cleanse their mouth before that. Candidiasis or thrush is the white patches that happen inside the mouth of our patients, their tongue or their esophagus, and it is very uncomfortable and can sometimes be painful. We do recommend to treat this with nystatin and not to eat or drink for about half an hour after you've given the treatment. They can also swallow the nystatin solution that's prepared by the pharmacy to treat any thrush that's in the esophagus. Just 2 more things in terms of nursing care. And again, this is basic nursing techniques that we've been talking about today that we often find in palliative care. But stoma care, it's really important to improve the quality of life of our patients. So these would be patients who would have had surgery for a colostomy or even a tracheostomy, which is in their throat, to help with breathing. It's very important that we assess outside of the skin, that you can access good quality products if available to prevent any skin breakdown. So if you do have questions or patients that you need more help on this, I'm happy to support. But it is really important that we take responsibility and support patients with these kinds of stomas. And the last one in terms of nursing care is lymphedema. So lymphedema is when you have a collection of lymph fluid in the interstitial space due to decreased drainage or a failure of the lymphatic system altogether. Oftentimes it happens in our breast cancer patients, can also be in patients that have cancer that is metastasized to their lymph nodes. Again, this is a kind of a pretty specific area of nursing. And if you do have further questions about it, please do reach out to our team. We have, again, a large faculty that can support and can help you. There is some techniques for massaging and wrapping arms and legs that can really help and provide support and improve people's quality of life that have these symptoms. The management for lymphedema generally is skincare, compression, so that's the wrapping, maintaining exercise of the limb that has been has the issue, and then also the massage that I was talking about. So just in summary, as we talked really briefly today about some of the nursing issues and concerns in palliative care, these are just some basic ones. Nurses are very smart and very educated. Please use them on your team. And if there's something new that you learned today as a nurse, I hope that you will be able to integrate it into your practice. So thank you so much for that.
Thank you, Erin. There's just a couple of questions in the chat. One was, could you clarify the use of hydrogen peroxide for the use of dirty wounds?
Yeah. So it still is highly recommended not to use antiseptics because we know that the antiseptics kill the bacteria, which is very true, but it also kills any cells that we're trying to grow and heal the body. I know it's not common, and I know it's very common to use antiseptics to clean wounds because oftentimes in many settings, we don't have necessarily clean water. So if a patient has clean water compared to an antiseptic or dirty water compared to an antiseptic, they would choose to use that. In your facility, I would strongly recommend that you switch to using normal saline. It is better for wounds, and hopefully over time, you will notice that the wounds will start to heal a bit quicker.
Thank you. And I see one more question about the difference between the maggots and the septic wounds and those used at KNH for chronic wound care.
Yeah, we actually have a palliative care nurse, but I don't think, you guys remember Gladys? She works at KNH. I do know there is some research out there related to medical maggots, isn't it? And they get rid of, I think what those maggots do, it's not the types of patients that most of you would be seeing, I believe. It would be, it wouldn't have happened organically. Those maggots are used to get rid of eschar, I think they call it. It's the black tissue that is killed, dead in wounds. And I don't have a lot of information, but I definitely can look it up. But those are in very specific situations, not the general wound that we see in palliative care that has a maggot. Most of the wounds that we would see that have an infestation of maggots would be patients that would be coming from home, and they've just probably had enough of the wound and they don't know what else to do, so they come into the facility and ask for advice. But I do know, Annalise, I also know you. So Annalise, I can definitely reach out to you. But I do know what you're talking about. I just don't have it on the top of my head right now, but I'll follow up with you.
And then I just see that, do you see the, oh, go ahead. I
Yeah,
think
it's
somebody also
interesting
has a question.
Yeah. I'll just make one more comment. I think it's interesting sometimes in medicine in nursing, when we use one thing and we've been told to avoid it for so long, and then, you know, someone finds another reason or another way to use it. So I think it's always good for us to try to be up to date on research and talk with our colleagues about what's working in their settings. That can also help. But yes, Dang, did you want to explain?
Good. I just want to try it. I know it would be a bit difficult. Are you getting me now?
Yeah.
Of course. Let me. The reason why I said let me try it. I see it's a bit quite difficult for some people to know the maggot. Of course, in some part of the world, if you see a dead animal, so which is not even also nobody used that animal. It was just like when the plight land on it. So as has been explained before by
Bang, I think
the lecturer.
Yeah.
Hello. By the lecturer. So yeah. So if you see a dead animal whereby you see a lot of plight, the sun plight, the normal plight land on it, so they produce some eggs. Those eggs they remain in the meat, so they put themselves as a living insect, which can also see them. They move like those caterpillar look like they look white, so they move in the wound. So if the wound was not clean, so those are the how we normally used to see them in our area, which is Africa. So of course we always see a dead animal, which is there's nobody use them. even also in a dirty wound which was not clean. Yeah, even in a human being which was not even also buried. So you see a maggot, they move, of course, they move like a living thing.
Thank you. Yeah, I think the biggest thing that from today at least is that you want to obviously take those wounds very seriously. Any patient who has maggots in their wound, it's I can't imagine how that would feel, and we definitely would not be able to heal the wound in those situations. The best thing to remind family and patients is to make sure wounds are covered. There's a lot of knowledge that air needs to get at wounds so wounds can heal, but especially in situations where people have reduced immunity and difficulty healing wounds anyways, if they have a diagnosis of cancer or are debilitated, then you would want to make sure all their open wounds or any skin breakdown is covered. There's a few questions here about for bleeding. Can you use adrenaline on the gauze? And what about tranexamic acid, sulfate? I see Dr. Esther Napula. Do you know the other name of the sulfate tablet?
No, I just know them as sucralfate. That is the generic name. I don't know the brand names.
Okay. And what do you all do in KNH for bleeding or?
For bleeding wounds, if it's cancer wounds, we do radiotherapy.
Right. Okay. And do you do
And then,
anything
yeah, if it's not cancer wounds, sometimes we also have the surgeons to review and see if they can cauterize those wounds in theater.
Right.
Yeah. All right.
Okay. Ruth, do you have any experience from your work in East Africa about the wound care? Ruth is our other nurse on faculty. I think you're muted, Ruth.
I've seen, I cared for a patient with maggots and using turpentine, so drew the maggots quite successfully. You just sort of hold it near and it sort of draws them. But it is a horrible situation for patients. Of course, they're very itchy as well. But with the maggots, I mean, the ones used for sloughing to de-slough a wound, they use them in this country as well, in the UK, but they're specially obviously bred in sterile conditions and used, monitored. So, and I've never seen them used in that situation.
Yeah, I can definitely share on the group chat. I think someone just shared a link, but they are, in general, I don't know for sure, but I would say the majority of the maggots that we would see in palliative care are not medical or therapy maggots. They would be just from someone being at home or being in a situation where they would have occurred kind of naturally.
The other thing that's very good for fungating wounds is using charcoal dressings if you can get them, or even sometimes charcoal crushed and put between gauze can help. If you've got no other wound care, just put that on with some Vaseline on one side so it doesn't stick. Or put the dressing first and then the charcoal on top, and that's quite good at taking smells away.
Yeah. There's just a few comments about flagell. Yeah, Dr. Zickley, we were talking about using metronidazole for the foul smell of those fungating wounds, and that's in the presentation. I think you might have missed that part. And then surgically removing dead tissue, that is really important. Debridement, we call it in nursing and medicine, and making sure that if accessible, that you remove any dead tissue, because the skin can't heal if the dead tissue is still there. So those are good. And then just one more comment from Dr. Hunter, the tranexamic acid for the bleeding can be applied by crushing tablets and putting it directly on the wound, or soaking the solution on a piece of gauze. So a few different options there. Okay, thank you so much for an interesting conversation. I'm sure we could talk about wound care in palliative care for ages, or maybe I could. But let's move on to the case, because I think that will help us wrap up this session for today. And you can put questions, continue to put questions in the chat. We won't do breakout rooms today, just because we had the 2 topics to cover in the presentation. So this case presentation will be of a patient related to their end of life care. So I want to introduce you to Ali. He is a 54-year-old man who has lung cancer, COPD, and is experiencing cachexia. He was seen in his home, his family home where he lives within a refugee camp. He was very tired and weak when the home care team visited him, and he had been gradually declining in functional status over the last 2 weeks. He had been on bed rest for nearly the last week, so the last 7 days. He was sleeping for longer periods of time each day, now only awake for a few hours. He was managing to drink small amounts of liquid yesterday, but today his swallow is very weak, and even after a few sips of fluid, he starts to cough. He was having confused speech, and he was asking to see his relatives who had died previously. So based on some of the discussion we had with Dr. Hunter about end of life and patient's prognosis, in the chat, if you can share, or you can unmute or put your hand up and unmute, what do you think Ali's prognosis is? And then if you give a prognosis, why do you think it's this way? What reasoning do you have behind that? So when we talk about prognosis, we mean how much longer do you believe Ali has to live?
Prognosis.
Yeah, Abraham, did you want to share?
Imminent death syndrome. Oh.
Right.
Yeah, I wanted to say something.
Okay, go ahead.
Accordingly, the prognosis of that patient is very poor.
Yeah.
The prognosis of that patient is very poor, and he's dying in a few days. So it's better to continue and have the care of life. It's better to do it, and what we are talking about, and they prepare their mind for whatever comes next. Thank you.
Right. Thank you, Abraham. You cut out a little bit, but I think we got what you were trying to share. So I see in the chat, a lot of people are saying poor prognosis, an hour to a few days, final days, imminent death. Yes, hours to days. I think you guys are right. And the reason that we would say that his prognosis is quite poor and he's in the last days of his life is because of the symptoms and what he's experiencing. So what are the symptoms that he is experiencing, and is there anything we can do to treat them, or how can we treat them, the symptoms of imminent death? So again, you're welcome to write in the chat, or if you'd like to share with the group, you can raise your hand. So what are the things that we are looking out for as our patients are declining and showing signs that they're in their last days of life? So confusion, poor swallow, yep. Aspiration, possibly. Asking for dead relatives, yep. The weak swallow. And I see Susan was saying we should try to manage any pain that he has, to position him for ease of breathing, and if he needs any anti-anxiety medication. What else can we do for this patient and his family? Dr. Hunter reminded us, as we discuss prognosis or we share with families and patients, it's usually best to use a range, for example, hours to days, days to weeks, or weeks to months. Give attention to the family and remind them of what's going on, yeah. Counsel the family regarding the end of life and their decline so they're prepared. Pain management and nursing care, that's really important. Physical as well as spiritual care. So for Ali, some of the things that we've identified is number one, his pain. So due to the cancer and the bed rest, he would be at risk for pressure sores and possibly having pain due to the advanced cancer. So we would want to use the WHO analgesic ladder to give us recommendations of, depending on what medication he was on before, if he's opioid naive, that sort of thing, to decide what's the best way to manage his pain. In terms of breathlessness, he would be having that symptom due to the cancer in his lungs and the COPD. And we know that one way that we can treat breathlessness or shortness of breath is with low doses of morphine for patients. We know he also was experiencing that delirium or the agitation, having possibly been seeing things or hearing things, which is common at end of life. We can recommend haloperidol or benzodiazepines for patients that are experiencing those symptoms. And the last one would be any respiratory secretion. So we were talking earlier about it being considered a death rattle, or the sound is quite common at the end of life, where the patient has a lot of secretions that are very loud. And for that, we can recommend hyoscine butylbromide to reduce the amount of secretions for the patient. Some other good comments coming through. Dr. Hunter, are you still with us? I think you're here. Sorry.
Yeah,
What
definitely.
What are your thoughts on a psychiatric review for Mr. Ali?
Yeah, did you say psychiatric? I missed the.
Yeah. Mm-hmm. Psychiatric review.
Yeah, I think it depends on the agitation that's happening and how much it's impacting either the patient's comfort or safety in the family. A lot of patients, as I mentioned in my presentation, are very delirious at end of life as their cognition is changing. Not all delirium needs to be medicated. You think of someone who is maybe appearing to be comfortable lying in bed, maybe talking to someone who's not there. Someone had a comment in the chat earlier about talking to family members, like dead family members, as a sign of close to end of life, which is very interesting. It's a very realistic observation that does seem to happen a lot. And I think that if those, if delirium appears peaceful to the patient and to the family, it does not necessarily need to be medicated. Agitation, and usually I think when people say agitation, they mean a hyperactive delirium, can be medicated usually we start with antipsychotic medications like haloperidol, which seem to be better tolerated and more effective in this setting when that's possible to give that medication. Benzodiazepines and other sedatives, I usually try to avoid if possible, because sometimes that can make the delirium much worse. Sometimes that is the only tool that we have to try. Sometimes patients who have been taking benzodiazepines chronically, if they are suddenly not on the benzodiazepines, can go into a very notable withdrawal and become very agitated, in which case it's important to give back the benzodiazepine. But I think mostly to, the unifying principle of symptom management in the last hours of life is doing everything that we can to help the individual to be comfortable, and not doing things that don't promote that goal, if that makes sense. So I hope that was helpful, Erin.
Yeah. Abraham just clarified where he's working, they try to include everyone on the team. So that's really helpful, Abraham. I think that's a really good part of working together as a team. If there's an area that maybe the medical team or his primary treating team is not able to manage, asking for help is really, really important. So that's good. I think in the situation, it may be difficult if the patient was at home to get a psychiatric view. I'm not sure how teams in certain settings work, but maybe a phone call or a consultation over the phone could help with some of those, using some of those medications. Okay, we'll move on. So the next question is, how do you share with the family that the patient is dying now, that Ali is dying? We talked a lot about this in the last several weeks, talking about communication and how to share bad news. How do we go about doing this? From all that we've learned now as we get even closer to the end of this course. Shem, did you want to share? I see you've unmuted. So what can we do to support the family? Yeah, spikes. Dr. Simon is saying spikes for breaking bad news. You can call the elders. That's really important, bringing the community around to support the family and the patient. I think that's really good. Being sensitive as we share news, being culturally sensitive. So do you guys remember what the spikes acronym or the letters stand for? So remember the setting, creating the setting that is private and comfortable for the family and the patient. The perception, understanding what the patient and family know about their disease and what's going on, the situation. Inviting the patient to and family to receive new information about what's going on, allowing them to say they want to know, or if they don't want to know, if there's someone else in the family that can receive the information. Knowledge or sharing the prognosis of what's going on and explaining that their loved one is dying and is in the last hours to days of their life. being able to engage in their emotions. So being empathetic towards patients and families, as this is a very difficult time for them. And then summarizing and coming up with a plan of how you are going to support the family during this time and the patient. So one way we could do this is by saying, Ali is getting weaker each day. I'm so sorry to have to tell you this, but Ali is dying. It is likely that he only has some days left. So that is a very simple yet clear way to share the situation. As we were talking earlier, of course, we need to be able to support the family, especially in palliative care. So,
yes, good evening.
sorry, what do you think the family could be concerned about related to Ali's situation? What are some concerns that they may have? If you would like to share on the group, just raise your hand. I can easily unmute you just so we know who wants to share. So they could be concerned, wanting to make sure their patient is comfortable during this time, of course, wanting to know if their patient could be possibly having pain. If they're starving, only giving small bits of liquid, but causing the coughing. What can we do to make them comfortable? That's really important. Oftentimes our patients can be concerned about what the medical team is doing. What are they doing to help their patient? And they may be anxious and wanting to know what the next step is. I think that's really important. A huge part of palliative care is reassuring the family that the team is going to be with them, that obviously we're not going to be discharging the patient. It can be tricky when there is a change of location, especially during the end of life period when families want to go home and we may not have access to home care or home visits. So it's really important in those situations that you prepare the family as much as you can before they leave the hospital, and just try to inform them of what's going to happen, and obviously share a phone number that they could call, reassuring them that they could return to the hospital if they needed extra help. So some of the concerns that we had thought of is the weakness and tiredness, the lack of oral intake. If Ali not Saiful could hear the family, and what to expect next. Those are all things that you also had shared. So I think as we just come to a close there on the case, I think it's really important that we do think about these situations before we face them in our clinical settings as a group. And we think about ways that we can support one another. We can come up with different techniques and even practice some of those responses, because it can be difficult, of course, to share information with a family that their loved one is dying and walk alongside them. And it's not easy to do that. But we have time, maybe 5 more minutes, and then I'll share a few announcements. If anyone has any final questions about the topics today or the case study. There's a comment here from Bang to limit the number of visitors to come. I think this is true, or it could be a time when certain families may want more people to come. So I think it's really important as a healthcare provider to make sure you understand the preferences of the family and the patient. It may be a time where people want to have a smaller circle of people surrounding the patient, but it also might be a time when they would like to invite others to see their loved one before they die. So that really depends, I think. I think it's really important if you are in a hospital to try to allow what the preferences are for the patient. If they do want more people to come, to find ways to make that all right. Well, I think there may not be any more questions. I know, especially on days when we have these kind of heavier topics, palliative care is a very rewarding field of medicine and nursing, yet there are times when it can be a bit heavy and overwhelming. So I do hope all of you have something nice to do shortly after this call. I'm going to go get a coffee. I don't know, Dr. Hunter, what you're going to do. But it is really important that as we talk about these heavy things, we also are just reminded that we also need to take care of ourselves. It's very important that we do our work very well. And then also, I don't know, go for a walk. I can see some of you are walking right now, but go for a walk and get a breath of fresh air. Dr. Ali, are you with us? Dr. Zippy? I saw you were online for a little bit.
I'm here.
Okay, any
Sorry.
closing thoughts? You've been, I don't know if you've been, maybe you and Ruth are the ones who've been working in palliative care the longest. What do you do after you've had one of your patients die, or when you talk about these kind of heavy end of life situations?
Well, I think I talk to my colleagues.
Yeah.
Most times you probably have been taking care of this patient with other colleagues, so you're not alone. So it's good just to have a chat with your colleagues, reflect on what has happened and the support that you gave for this patient, and of course, never to blame yourself because it's beyond us when a patient is dying, and because we've done all that we can. And so we need to also just celebrate that we have been there for this patient and the family, hoping that we have been there for this patient and family. And so usually I tell people that when our patient dies, do we ever get back to the family to help them with bereavement, to even just say we are aware that the patient does, to kind of empathize and be there for them. That's really helpful for the family. But again, sometimes when you're over involved and really hurt as a healthcare worker, just like you said, we recommend you share your thoughts with other colleagues, with a friend, not necessarily their family because they are not healthcare workers, they will not understand, but also just do something to make you, if you're doing your nails is what makes you happy, if going to watch a movie, all those things, if doing comfort foods is what makes you happy, you can indulge at these times of this kind of time, because you want to also be able to be strong in terms of if the patient's family comes back to you, how are you going to interact with them? So I think you look at what makes you feel better than just about death, and try to do that. But again, working with colleagues is very important, because you build a health sort of a support system within the healthcare workers. So it's good to also share your patient with other healthcare workers, so that it's not really a big burden on you when they pass away. Thank you.
Ruth, do you want to add? I know you've been a nurse, palliative care nurse for many years.
I think, often we've traveled a long time with these patients and we get quite close to them. So as Dr. Ali said, I think we really need to recognize our own emotions around this and to share them with the team. And very often it's quite useful to have a team meeting a few days later to talk about it, but also to see if there are any learning points. Could we have done better with the things that we would have changed now with hindsight? So, you know, it becomes a bit of a learning case as well. And we always told the family that we'd be back after a few days just to see how they were and to help them look at their bereavement, because often, you know, there may be children involved, maybe it's the first time they've ever been involved with the death, and so there are all sorts of emotions for the family that you know, the shock may sort of mask this at the time of death, but you need to go back afterwards just to see how they're doing and give them support.
I'll just let Dr. Anna, if you have any final comments, and then Dr. Esther. I know you guys have been monitoring the chat.
No, nothing from me. Great session, and thanks for everyone for your presentations and participation.
Dr. Esther, do you have any comments on end of life or the nursing or the case studies?
I also have no comments. They were quite insightful sessions today.
Thanks for being with us. I'm not sure who KEHPCA is. Is it David or Macklin? I don't know who you are today, but if you have any final words, then I'll just make a no comment. Okay. So I'll just wrap up today. So next week is our final session. So we've done 11 calls or classes over the last 2 months, and you guys have been great. I think on average, we have about 70 to 90 participants each week. It's really amazing that you guys have continued to come out on a regular basis. We do know that there are times, of course, that you can't join or the network was down. So what we've done is we'll share the link for a makeup quiz. So any participant that was not able to attend a session, hopefully you remember which session you missed, you have the ability to make up that session by listening to the recording, the YouTube recording that I put up every week, and then participating in a 5-question quiz. The quiz will come out as a Google form, and you just need to choose the week that you missed and then answer those questions after you listen to the recording. Once you've done that, then we would mark you as present for the session. So our administrative assistant is working on the attendance list, and hopefully after the final session, we'll have a good idea of people that want to receive their completion certificate. And to receive that, you'll need to complete all of the sessions. So that's just to make sure that everyone has had the same access and has spent the same amount of time covering the content to get the completion. So please do look out for that link. I will try my best to share it probably next week. We're just finalizing the quiz to make sure that the questions are suitable for everyone and up to date. So please do look out for that link if you have missed any sessions, and don't hesitate to email us at our email or message on the WhatsApp group. We will take a break after next week from all the teaching, and then we will prepare for our second group or a second batch of participants. So you're welcome to share around with colleagues that didn't get to join in the first group. But next week we'll actually be talking about debriefing as a team and self-care in palliative care. So I do hope that you can join us for that. And if not, I think that's everything for today. Thanks for joining, and it's really good to see each of you. Thanks, everyone. Bye-bye.
Bye.
Thank you.